Thank you, Aditi, and thank you, the organizing committee, for this opportunity to talk about KELIM. And as Aditi said, it is a very important and exciting clinical biomarker that we must try and use in our clinical practice, especially of course, in ovarian cancer. And in this presentation, basically, I'm going to walk you through how we came about discovering KELIM and what is the clinical utility of KELIM, what are the various clinical avenues in which this biomarker has been tested, and what is the future of this biomarker as a prognostic and a predictive entity in ovarian cancer. So we all know that locally ovarian cancer is, especially when diagnosed in the advanced stage, the cervical outcomes are quite dismal, and there is a lot of debate as to whether these patients with locally advanced ovarian cancer need to be first treated with neoadjuvant chemotherapy or surgery, and there is an indication, and NSAT is a valid approach, especially when there is extensive peritoneal disease. We also know that the components of treatment of locally advanced ovarian cancer involves a very good surgical site reduction, and the intent of this surgical site reduction is to achieve no gross residual disease. And to further consolidate this surgery, there are various locoregional therapies that have been employed: intraperitoneal chemotherapy, hypothermic intraperitoneal chemotherapy, but the mainstay continues to be aggressive locoregional surgery. I have also already mentioned about the various local regional therapies that complement a good surgery. But despite all these treatment efforts, the problem with ovarian cancer is that recurrence is common, and most of the recurrence does happen again in the parietal peritoneum and in the lymph nodes. We need to identify clinical biomarkers which will probably help us in aiding treatment. So we know that sometimes, and in some group of patients, these aggressive surgeries, local regional therapies may not be enough, and there may be certain things that we need to do more. And who are these patients? So we need, especially in ovarian cancer, clinical surrogate biomarkers are lacking. Perhaps one of the most important biomarkers that we are already using in ovarian cancer is CA-125. And the CA-125 is actually guiding us in making a lot of therapeutic decisions. But there has been, in the recent years, a different approach to studying and analyzing the kinetics of CA-125 monitoring. That is exactly where this application called KELIM comes. So how did this evolve? So in standard practice, as per the GCIG criteria, especially after neoadjuvant chemotherapy, a 50% reduction in the CA-125 levels, which is maintained over a period of at least a month, is normally taken as a clinical response. And this value of CA-125, along with imaging findings, is taken as an indication for feasibility of cytoreductive surgery. However, this definition of the GCIG was challenged in a retrospective observation from the ICON-8 post-hoc exploratory analysis by Morgan et al. And they found out that in 50% of patients, if we were to use only this criteria, 50% of the patients after neoadjuvant chemotherapy still were able to undergo a optimal cytoreductive surgery. So there was definitely an underestimation of CA-125. Similarly, in another exploratory analysis of the Calypso trial, the investigators concluded that an early decline of CA-125 did not necessarily mean that there was a tumor response, and this tumor response did not necessarily mean it had an improvement in survival. So in the background of these observations, investigators felt that there was a need to address the kinetics of CA125 measurement, and they probably came to the conclusion that a longitudinal assessment of CA125 perhaps may be more accurate than a single or a two threshold value, and thus emerged by this clinical biomarker called KELIM, and this was basically the product of investigation done by Benoit Yu et al. So what is this KELIM? It is basically a semi-mechanistic model. I think it is a very clever model in which they have adopted pharmacokinetic properties to measure the CA125 value. So basically, of course, you cannot measure the quantity of chemotherapy directly into the blood, but the indirect effect of the chemotherapy on the CA125 production was measured, and the rate of decline of this CA125, which was nothing but taken as the marker elimination rate, that was what was recorded as the KELIM, and a semi-mechanistic model was developed. And so what truly is the clearance or elimination is not a true clearance, but the rate of decline of the CA125 level in the blood, and this clearance is of course not related to the liver or renal function. So what this KELIM has actually done, and what is unique about the KELIM as a biomarker, is that it reflects the primary chemosensitivity of the disease, and this reflection of primary chemosensitivity has, through various studies, retrospective studies in large cohorts, has actually shown an improvement in overall survival and disease-free survival. So how is this KELIM assessed? There is a software that is already available on the internet for us to use, which has been validated by the French group, and the ideally three measurements of CA125 level has to be recorded within 100 days of the start of the chemotherapy. These values are then fed into this model, and the KELIM score is given. This KELIM score is a standardized KELIM score, and for the ease of clinical application, the score has been divided into a favorable score, which is greater than 1, and an unfavorable score, which is less than 1. Now, what is the clinical utility of this KELIM? And the most important utility is to determine whether the disease that is being treated with neoadjuvant chemotherapy is chemosensitive or not. And the other utility is whether the post-neoadjuvant chemotherapy, the KELIM score can actually predict whether one can achieve a complete cytoreductive surgery. And of course, it has got a prognostic implication, and also it helps in identifying patients who will be susceptible for a platinum-resistant disease or platinum-resistant relapse. So what is the ensuing evidence with regards to the clinical utility of KELIM in various studies? Most of these studies have been retrospective in large cohorts, and everywhere they have found that a favorable KELIM increased the probability of optimal cytoreductive surgery at interval cytoreductive surgery. Similarly, a database comprising of 8 first-line trials of nearly 5,884 patients in order to understand the prognostic impact of KELIM again showed that an unfavorable KELIM score had a poorer survival as compared to a favorable KELIM score. And when this was adjusted for surgery, it was found that patients with a favorable KELIM score and an optimal cytoreductive surgery enjoyed a very good median overall survival as compared to patients who had an unfavorable KELIM and a suboptimal cytoreductive surgery. Interestingly, patients who had a favorable KELIM and a suboptimal cytoreduction still did enjoy a reasonable overall survival. So here, when you adjusted for surgery, or when you kept surgery as the main factor, the KELIM emerged as a very important prognostic factor to tell us which patients will recur despite an optimal or suboptimal surgery. With regards to maintenance therapy, there always has been a debate as to which patients should receive maintenance therapy and not. And there is a indication for giving maintenance bevacizumab in patients of high-risk patients who are suboptimally cytoreduced and in stage 4 disease. By definition, all these trials had used less than 1 centimeters as the criteria for optimal cytoreductive surgery. So if you were to technically see 20 to 40% of patients who by definition are optimally cytoreduced also do have residual disease. So what would perhaps be the approach for maintenance therapy after a complete cytoreductive surgery or a CC0 surgical cytoreduction in the interval setting? Is there a group of patients who can benefit from some kind of maintenance therapy despite achieving a CC0 cytoreduction? That is a question that perhaps we need to answer, and perhaps KELIM and some other clinical biomarkers may help us to identify such group of patients. So in a retrospective analysis of the ICON-7 study, they found out that when KELIM was applied, only those patients with an unfavorable KELIM and high-risk disease had a benefit with bevacizumab. In patients who had residual disease, despite residual disease, but a favorable KELIM, adding bevacizumab was of no further prognostic benefit. So only these group of patients who have a high-risk disease and an unfavorable KELIM should be subjected to bevacizumab, irrespective of the type of cytoreduction. Similarly, KELIM also has a role in identifying patients who will benefit from PARP inhibitors. So in this exploratory analysis, they found that patients who are BRCA mutated and HRD mutated and with an unfavorable KELIM are so bad prognostically that adding or giving PARP inhibitors is not going to change their disease biology. So only those patients who had a favorable KELIM and a BRCA positive, BRCA mutated and HRD positive did benefit from the addition of PARP inhibitors. So again, KELIM here acts as a potential predictive factor for the use of judicious use of maintenance therapy. Similarly, we decided to conduct a multicentric study in our group of patients. 4 centers from India participated in this study, and we wanted to find out what was the best possible value of KELIM and pathological PCI that could probably prognosticate patients in high-grade serous epithelial ovarian cancer. And we also wanted to correlate KELIM score with other pathological parameters. So in our group of patients, almost everybody achieved a CC0 cytoreduction, and a complete pathological PCR was achieved in 11% of patients. So there was a linear negative correlation between the KELIM score and the pathological PCI, which means a higher pathological score was reflective of a lower KELIM score and a poorer prognosis, and a higher KELIM score was and a low pathological PCI was reflective of a better prognosis. We did a maximally selected rank statistics to find out the optimal cutoff value for KELIM, and which was 1, which also correlates with the one existing in literature. When we separated the prognosis on the basis of this KELIM score, we found that patients with a higher KELIM score did prognostically better than the patients with a lower KELIM score. Similarly, we found out the optimal cutoff value for a pathological PCI as 8 in predicting survival. And when this was separated by the pathological PCI, we found that patients with a higher pathological PCI after a CC0 cytoreductive surgery had a poorer prognosis as compared to patients with a lower pathological PCI. So to conclude that following interval cytoreductive surgery, despite an optimal complete cytoreductive surgery, a pathological PCI of 8 and above and a KELIM score of less than 1 are poor prognostic indicators. So what is the clinical connotation of this study? Here we are talking of a very select group of patients who have undergone a complete cytoreductive surgery. If we have criteria, the patients we are selecting for maintenance therapy and bevacizumab are patients who have some amount of residual disease. Here I'm talking of patients who don't have any residual disease post-surgery. In these patients, are there patients who may benefit from maintenance therapy? So my hypothesis perhaps is a patient with a low KELIM and a high PCI may benefit from a maintenance therapy. A patient with a high KELIM and a low PCI may not benefit from any kind of maintenance therapy, irrespective of the stage. So the efficacy of subsequent addition of maintenance therapies needs to be evaluated, and we have to select our patients well who, and these clinical biomarkers such as KELIM and other pathological biomarkers like the pathological PCI may help us to identify these group of patients who may benefit or not benefit from further maintenance therapies. And we have to test the utility of these clinical surrogate biomarkers in the real world setting in order to aid treatment individualization. Thank you.